So I'd like to introduce the next speaker, Dr. Robert Andtbacka from the C.M. Huntsman Cancer Institute, Salt Lake City. And Dr. Andtbacka is going to talk about a trial for melanoma, skin melanoma.
Yeah. Thank you very much. I wish to thank the organizing committee for giving me the opportunity to talk to you here today. Specifically, what I'd like to talk about is Talimogene laherparepvec, also known as T-VEC, and how this is really changing the treatment of metastatic melanoma. And in terms of my disclosures, I do have research funding from Amgen, who is the sponsor of the clinical trials that I'll be talking to you about. Now, oncolytic immunotherapy is something that is not new. We've been doing this for over 100 years, but this has changed quite dramatically in the past 20 years, where we now use both viruses, small molecules, and also mechanical ablation to treat tumors directly. And the reason for this is really to have an oncolytic effect on the tumor. But also with these therapies, we also like to try to have an immune effect. So we activate the immune system locally where we've treated a tumor. And this immune effect then is to activate against tumors at non-treated distant sites. Melanoma has really been in the forefront of developing these oncolytic immunotherapies or intralesional oncolytic immunotherapies. And this is just a few of the different agents that have been developed. Now, as you can see, most of these are in phase 1 or phase 2 evaluation. There are a few that have gone through a phase 3 evaluation. But to date, the only approved agent, intralesional agent for the treatment of metastatic melanoma is Talimogene laherparepvec, also known as T-VEC. And that's what I'd like to focus on for the remainder of my talk. Talk a little bit about how T-VEC was developed and where we are going with T-VEC, both in melanoma and also at the end in some of the other cancers. So T-VEC was approved both in the United States and in Europe over 2 years ago. And really what I'd like to focus on in my talk is really to talk about the mechanism of action of T-VEC, the safety of this. I think internationally there has been some concern that we are using a virus to treat patients with metastatic melanoma. Talk about how this is used as a monotherapy, but also in combination. And really how these oncolytic immunotherapies can change the tumor microenvironment and potentially make tumors more responsive to other treatments. And also talk about how we are using this in a neoadjuvant setting. So first of all, let's discuss sort of the mechanisms of actions and safety of T-VEC. So T-VEC is a herpes simplex derived oncolytic immunotherapy. It has been genetically modified, and part of that modification really has led the virus not to develop herpetic infections in individuals. It also has insertion of GM-CSF, which is believed to further activate the immune system when we inject T-VEC into tumors. And the way this is done is, or I'd like to describe how we do this with this small cartoon. So patients who have metastatic melanoma that are either dermal, subcutaneous, or lymph node metastases can be injected with T-VEC. And when we inject T-VEC into these tumors, the virus is primarily taken up by tumor cells and not normal cells. And inside the tumor cells, the virus then undergoes replication, which leads to lysis of the cell. And we believe that there is also production of GM-CSF. And this then leads to activation of the adaptive immune system, specifically through the dendritic cells and then activation of T cells. And these T cells then seek out melanomas at distant sites, non-injected sites, and destroy them. So looking at then the safety of this, one of the concerns that has always been there is that, well, how is this safe for not only the patients, but also the family members and healthcare providers? So we've done quite a few studies of this, and I'd like to just summarize this. And actually last year at this conference, I presented on one of our shedding studies looking at T-VEC. And so I'd like to summarize the data from that study, but also some other information that we have. And really when we inject T-VEC into the tumor, the highest detection of DNA is in the injected sites. There's also transient low levels in the blood and urine. However, this is not at the infective dose. And also, when we inject this, we put an occlusive dressing on top of the lesion. And this is actually a very effective barrier against T-VEC. And really, we don't find any virus on the external surface of this exterior dressing. We ask the patients to keep that on for 7 days. And this has also been shown to be safe for family members. in that we really have not found any transmission of the virus from the patients to either healthcare providers or family members. In terms of mechanism then for this, or in terms of the monotherapy for this, so the study that led to approval of T-VEC is called the OPTIM study, and this was a randomized phase 3 study run in the US, UK, Canada, and South Africa between 2009 and 2011. And this randomized patients that have had at least one dermal, subcutaneous, or lymph node metastases of melanoma to receive intralesional T-VEC, and the comparator arm was the subcutaneous GM-CSF. The reason this was chosen is that GM-CSF is being produced by T-VEC. The primary endpoint was durable response rate, and this was defined as a response lasting 6 months or longer. It's actually a very difficult primary endpoint to achieve. And secondary endpoints included overall survival as well as overall response rate. So the type of lesions that we inject with T-VEC includes dermal lesions, as you can see on the left side here, subcutaneous lesions, and also superficial lymph nodes. We can also inject deeper lymph nodes. In the left upper hand corner is a CT scan of a patient with an enlarged external iliac lymph node that we can inject under ultrasound guidance. But as part of the study, we did not inject visceral lesions such as lung metastases or liver metastases. Now this has been done in subsequent studies where we actually are using this agent for liver metastases, specifically in patients with colorectal metastases. So let me show you a video here of one of my patients where we inject an oncolytic virus. So this is a patient who has a metastatic melanoma in a lymph node in the right neck, and we inject this in the normal clinic setting. There is really no special precaution, with the exception that the injector wears a shield, a gown, and gloves. And this is actually very well tolerated by patients. Now when we inject this, we try to go really at the periphery of the tumor, where we have lymphocytes. And the reason for this is that we really want to try to activate those lymphocytes when the virus gets into the tumor and then leads to the activation of this. As you can see here, this is very well tolerated by the patient. And after we've done the injection, we put an occlusive dressing on the area, and the patient then goes home. Also in terms of safety in the clinic, there's no special cleaning up that needs to be done, and there is no special room that needs to be done for this. So looking then at the primary endpoint of the OPTIM study, which was the durable response rate, we can see that in the T-VEC arm, this was achieved in 16.3% of patients compared to 2.1% in the GM-CSF arm. The overall response rate was 26% with T-VEC and 5.7% with GM-CSF. Now you may say, well, that doesn't sound very large. But we have to remember when T-VEC was developed, the response rate for the therapies that we had for melanoma was in the single digits. Now, subsequent to this, we have now newer therapies over the past 5 to 6 years that have furthered this response rate. Interestingly also is that the patients who respond to T-VEC, almost the majority of patients have complete responses. The secondary endpoint included overall survival. Now, this was not statistically significant. The p-value was 0.051. However, there was a difference of over 4 months in median survival compared to the T-VEC arm and the GM-CSF arm. As later analysis of when patients had been followed for at least 3 years showed that there was a statistically significant difference in the overall survival between the T-VEC arm and the GM-CSF arm. So based on this, T-VEC was then approved in the United States for patients with unresectable metastatic melanoma. Now, our European colleagues looked at the data a little bit differently. And they sort of said, well, who were the patients that benefits the most from T-VEC? And on the left-hand side, we can see that the patients with stage 3B, 3C, and stage 4 M1A, now these are patients who have not yet developed visceral metastases, so no lung and liver metastases. They were clearly the ones that seemed to benefit the most from T-VEC. You had almost a doubling in survival in these patients seen in blue compared to in yellow for GM-CSF. Whereas in patients that had lung, liver, and other visceral metastases, there really was no difference in the overall survival for this. So based on this, in Europe, the approval is actually for these earlier patients, the stage 3B, 3C, and stage 4 M1A. And if we look at those patients specifically, we can see that the durable response rate in those patients is greater than in the overall patient population at 25%. And the overall response rate is also larger at almost 41%. And again, there as well, we can see that 41% of patients have a complete response. Now, how does this then compare to other treatments that we have for melanoma? Now, we've never compared these head-to-head. However, if we take these patients with earlier disease that have not yet developed distant disease, so these are the patients with in-transit and lymph node metastases, we can see that T-VEC stacks up fairly well compared to some of the standard therapies that we have for melanoma, such as PD-1 inhibitors and anti-CTLA-4 therapy. So let me show you some images of what we find in clinic. So this is one of my patients that has in-transit melanoma on the arm. When we inject T-VEC, it is quite common to first see a fairly robust inflammatory reaction at the injection site. But over the next few weeks, we then see responses in these lesions. And this patient is now over 4 years out and still has no evidence of disease. This is another patient that has a melanoma on the ankle. Now, as you can see here, it is not uncommon for these lesions to grow when we inject these oncolytic viruses. And the reason for that, you have a fairly robust influx of immune cells into the tumor that leads to this pseudo-progression of them. But then over time, the tumor dies and the area gets smaller. So looking specifically at the injected lesions, we can see that 64% of all injected lesions had a response to T-VEC. And as seen in green here, the majority of those actually had a complete response. Now, ultimately, though, we don't only want to have responses in the injected lesions, we also want to see an activation of the immune system. And this shows a patient that has a lot of in-transit melanoma on the leg. We only inject a few of these lesions, but over time we see response not only in the injected lesions, but also the non-injected lesions. And again, looking at these regionally non-injected lesions, the response rate in those was 34% with T-VEC. And again, the majority of those non-injected lesions that responded had a complete response. What about distant metastases? Now, on the OPTIM study, the amount of distant metastatic disease the patient could have was fairly limited. However, this is one patient that had disease around the right kidney area and also in the subcutaneous area on the left flank. And these areas were not injected. The left flank was injected, but the right kidney area was not injected. And the patient had responses in both of these. So looking then at those visceral metastases, the response rate is 15% with T-VEC. Not as great as we would like it to be, and I'll get back to that shortly here. In terms of durability, if the patients respond to T-VEC, the responses tend to be very durable, with 65% of patients having a response that lasts 12 months or longer. Now, recently we also looked specifically at the patients who had a complete response and asked, well, how likely were they to recur if they've had a complete response? And what we found was that if patients were still in a complete response around 3 years, the likelihood of them recurring was actually very, very low. And we can see from this that over 70% of patients who had a complete response at 3 years maintained in a complete response. In terms of safety, T-VEC overall is extremely well tolerated. The most common side effects includes a bit of shakes, chills, fatigue. But the more severe toxicities, the most common one was cellulitis at the injection site, and this was 2%. Again, fairly low compared to many of the treatments that we have for patients with metastatic melanoma. Now let's get back to then these patients with visceral metastases. I think that clearly T-VEC is an option for patients that have more limited disease. But if patients have lung, liver, and other metastases, I do think that we need to think about using this in combination with other therapies rather than as a monotherapy. So let's discuss that and talk about some of the studies that we've done for this. So the first study that we did was combining T-VEC with an anti-CTLA-4 therapy called ipilimumab. And this has been approved, the ipilimumab has been approved for patients with metastatic melanoma. And in this study, patients were randomized to have ipilimumab by itself or T-VEC and ipilimumab. And the primary endpoint was overall response rate. So the first thing that we always want to make sure when we combine therapies is there an additional toxicity by combining this? And really combining T-VEC with ipilimumab, there was a slight increase in the more severe toxicities, but this was not statistically significant. And still the majority of the toxicity that we see for these patients comes from the ipilimumab and not from T-VEC. Looking then at the primary endpoint, the overall response rate was 39% in patients on T-VEC compared to 18% on patients on ipilimumab. So it really shows that by adding these two agents, we can have more than a doubling of the response rate. and really sort of seemed to have an additive response rate compared to what we would have with the ipilimumab by itself. Also, there was an improvement in progression-free survival, albeit quite modest, but this again showed that by adding T-VEC to ipilimumab, we have an improvement in that progression-free survival for patients. We have also combined this with another agent called pembrolizumab, which is an anti-PD-1 therapy. And we have done this in a phase 1b study where we combined these two. And in this study, we had 21 patients who participated in it. And first of all, there really was no added toxicity. So anti-PD-1 therapy in general is much better tolerated than ipilimumab. And when we add T-VEC to the pembrolizumab, the anti-PD-1 therapy, there really was no added toxicity. And also here we saw a very robust response rate. And this response rate, it was 62%. And we saw this across all stages of disease. Now, I still think that this requires some caution. This is still only 21 patients. But it is encouraging that we can see this robust of a response rate. Now, pembrolizumab by itself in these patients with metastatic melanoma has a response rate of about 35%. So it appears that when we add T-VEC to this, at least we seem to have an additive response rate between these two agents. We have just completed a phase 3 randomized clinical trial in which all patients get pembrolizumab and then are randomized to either a T-VEC placebo given intralesionally or T-VEC given intralesionally. And the data from this should be forthcoming in the next year or so. Now, the one thing that is one of the challenges in melanoma is patients who are treated with many of these checkpoint inhibitors, such as pembrolizumab, is that they may not respond to that. And usually one of the reasons for that is that they don't have the appropriate immune cells in the tumor. So the question then becomes, can we use these intralesional agents to change the tumor microenvironment to make these patients who may traditionally not respond to a PD-1 inhibitor become responders to that? So let me show you some data of sort of where we sort of look at this activation of T-VEC and activation of the immune system. So here we're looking at using T-VEC in combination with ipilimumab. And what we found when we looked at the peripheral CD8 positive T cells, that there was an increase in those total number of CD8 positive T cells when we initiated the treatment with T-VEC. And this was further increased when we added ipilimumab to that treatment. In addition, the activated CD8 positive T cells also increased with T-VEC and was further increased when we added ipilimumab. So why is this important? Well, it's important because this also seems to correlate with response, in that in the patients where we saw an increase in both the total number as well as the activated CD8 positive T cells, those were the patients that were more likely to respond compared to the patients where we did not see this. So this is one potential marker that we could use to try to determine who will and will not respond to this combination of therapy. We have also then looked at sort of the changes in the tumor microenvironment in patients given pembrolizumab and T-VEC. And we know from other studies that the patients who respond the best to pembrolizumab or to anti-PD-1 therapy are the ones that have a higher number of CD8 positive T cells in the tumor, have a higher interferon gamma expression, and higher PD-L1 expression. And in our 21 patients that we looked at the tumor, we found that even in the presence of patients that had a low CD8 positive tumor infiltrating lymphocytes before we initiated the therapy, had a low interferon gamma signal and low PD-L1 signal, and we did not expect them to respond to PD-1 inhibition. When we started the treatment with T-VEC first, we were able to change that tumor microenvironment. And then when we added the PD-1 inhibitor to it, the patients then responded. And this is seen here where we look at these patients with a partial and complete response. And really what we found was that T-VEC increases the number of CD8 positive T cells in the tumor. And this is further increased with pembrolizumab, but probably also drives the response to pembrolizumab in these patients in that they have an improved response greater than we would expect to see had we not given T-VEC to those patients. Now, where are we going next with T-VEC? So one thing that we are looking at is really using this a neoadjuvant approach. Now, patients who present with metastatic melanoma, such as having small dermal metastases, small subcutaneous metastases, or lymph nodes and lymph node basins that we can resect, the current treatment for those patients is surgical resection, followed by adjuvant therapy. However, we know that even with the adjuvant therapy in that setting, the risk of recurrence for these patients is extremely high. And if we look at that, we know that the median time to relapse if we do surgery for these patients is between 9 and 18 months. And the 5-year risk of relapse can be as high as 85% in these patients. So what we have done traditionally is that we've done surgery and then given adjuvant therapy. Now, we're asking the question then, well, can we use these tumors now in situ and try to activate the immune system before we do surgery to try to decrease the risk of recurrence after we've done surgery? And when we look at the Optim study and look at the patients who responded the best to T-VEC, these were the unresectable stage 3B and 3C and stage 4 and 1A. These are the patients that have in-transit lesions or lymph node metastases. And these are the ones that clearly responded the best. The whole question was, well, why did they respond the best, and why did they have an improvement in survival compared to patients given GM-CSF? And looking at that data, we found that it appears that in the patients who were given T-VEC, they actually had a lower risk of developing visceral and bone metastases. So the question now becomes, can we use that then in these patients that have resectable disease where we can do surgery, but potentially treat them with T-VEC before surgery to decrease the risk of recurrence after we've done surgery? And we've completed a phase 2 randomized international trial in which we have randomized patients that have resectable stage 3B, 3C, and stage 4 and 1A disease to receive surgery up front, which will be the standard of care, versus T-VEC for 12 weeks and then do surgery. And we will be presenting some of this data at ASCO a bit later on this year. So, in summary then, intralesional T-VEC is very well tolerated with low toxicity. It exhibits an effect on both the injected and uninjected tumors. It is very effective as monotherapy, specifically in patients who do have minimal to no visceral metastases. In combination therapy, it also is preferred for patients that have visceral metastases, and at least in preliminary data, it appears to be quite effective in that patient population. It appears to enhance the effect of other immunotherapies in this combination setting, and also may be used potentially as a rescue strategy to reconstitute immune cells within the tumor microenvironment in lesions that are resistant to checkpoint blockade. And also, I think that this has a potential of being used in a neoadjuvant setting, although the data for that is still quite slim, but we are getting more data from the randomized clinical trial that I just described. So where is the development program moving? Well, this is being done in melanoma. We're moving forward with quite a few additional studies, but this is also being expanded to other tumor types, including pancreatic cancer, squamous cell carcinoma of the head and neck, hepatocellular carcinoma of the liver, and also some pediatric non-CNS tumors as well as sarcomas. So with this, thank you very much.
Time for one or two questions. Come up to the microphone.
Thank you. That was a very nice talk. John Gray from Audentes. It's a fascinating situation you've got here, being sort of a virologist thinking about developing these sorts of vectors. You have an enormous now bank of presumably tissue samples from patients that have or have not done better or worse. Presumably you could pull out nucleic acids from them, sequence them all, and see if you find evolved recombinants that are more effective, and you could score all the different variants you see based on the responses you've seen. Have you considered doing that?
Yeah, and so we have doing that. So one thing, I think one was the challenge with the Optim study, that it really we didn't have serial biopsies there, but we've subsequently now in the later studies, we've done serial biopsies, and there's a biomarker study that we specifically wanted to look at that, and that has been completed, and some of those results have been reported, but we're still analyzing that. In the combination data, we are doing serial biopsies on those patients as well, both in the injected and uninjected lesions, to really try to understand and look at these responses in there. So it'll be
Are you seeing changes in the virus as it goes through periods of time and migrates to different tumors?
So the virus itself, we have not really seen the virus migrate to the tumors. So it's really when we...
No, I'm referring to the sequence of the virus.
Oh, the sequence of...
Have you seen the sequence of the virus?
So we have not looked at that specifically, but that could be looked at. But it hasn't been, to date, has not been looked at. So, yeah.
Thank you very much for the great presentation. And I'm interested in the non-responder patients because for you show that the non-responder patients, they couldn't turn the tumor microenvironment from cold to hot. So do you think that if you change the timing or frequency of injecting the T-VEC, do you think that we could change those patients to non-responder to responder?
So if I understand correctly, I can change the timing of T-VEC injection. Yeah, it's something that we've debated quite a bit because with many other oncolytic viruses, we have a different timing in all of this. And I think that so the way we currently inject T-VEC, we inject it sort of the first injection and 3 weeks later we do the second and then every 2 weeks. Now, there has been some preclinical data looking at changing the different timing and so on. Now, clinically, we haven't done that. I can't really say if it would make a difference clinically. But it's something that we'd have to look at. I think that also with many of the combination therapy, it becomes a practical factor as well. How often can patients come in and when we do the injections? But it's something that we've discussed looking at, but we haven't done so far. So, yeah.
Thank you very much.
Yeah.
I have a question.
Yeah.
So thinking of improving this treatment with T-VEC over the future, there's a lot of work, thought going into assessing different combination therapies.
Yeah.
What's your view on how the vector itself might also be improved or changed or altered? Or do you think that is something that has been optimized and it's really a question of making it more effective with lots of new combinations and new adjuvants?
Yeah, it's a great question. I think that also is that, so I think that T-VEC is the first one that was approved, and I think that the saying is that the first one through the wall gets a bit bloody, and I think that we've learned a lot from this. I think that the subsequent treatments now coming out, both with herpes simplex virus, some of them use different vectors. Some of them actually have no inserted genes. Others have multiple inserted genes in there to try to increase that danger signal. So I think that Rob Coffin, who sort of really developed T-VEC, is developing additional newer herpes simplex type viruses as well. Now, what the optimal one will be, I think that we don't know. And the other thing also is that I think that much of this may also be patient-related as well, is that what works for one patient may not work for another patient. And we see that not infrequently in patients who go on one oncolytic immunotherapy and they don't respond to that, may have progression. Then we then start a second oncolytic immunotherapy, they have a response. And so I think that the mechanism behind this is quite different. So I think that although we can try to improve the viruses themselves, I think we also need to look at the host and look at the patient and the effect that will have on it. So, and in the end, my personal opinion is that may be more important than necessarily the virus itself, the construct of the virus. So.
Thank you.
Just one question.
Yeah.
So you treated a patient with a normal room, hospital. So how do you avoid virus shedding from a patient to other?
So we treated.
I mean, somebody I'm afraid that somebody infected with your T-VEC.
Yeah.
So how do you avoid how do you control viral shedding from a patient?
Or the viral shedding? Yeah. So the viral shedding, when we looked at that specifically, is that it is shedded in the urine and blood, but most of the time we just detect it by PCR. But it's not enough to be infective. The only area that's really the virus can be infective is if you swab right on the injected site. But elsewhere in urine, blood, and so on, the levels were detected by PCR, but they were not infective at that level. Additionally, also, just the way the construct of the virus is that we have no evidence to date that this causes herpetic infections in sort of non-treated individuals. Even in the individuals who have herpetic infections, when we swab them, we often find that actually most of the time we find it's not T-VEC, it's just regular herpes that they have. So, yeah.
So patient is hospitalized or out?
No, this is just in outpatient clinic, so we no need for hospitalization for this. So, yeah. Good.
Thank you very much again.
Thank you.